Buenos días a todos. A continuación vamos a seguir con el módulo de vía biliar, de cánceres de los ductos biliares, y para mí es un gran gusto presentar a una real eminencia en este sentido, dado que hay pocas personas que cuenten con tanta experiencia y tantas publicaciones, tanto como primer autor o coautor en cánceres de vía biliar tratados con radioterapia en cualquiera de sus settings, ya sea adyuvante o no adyuvante, dado el poco o la poca supervivencia o el pobre pronóstico que presentan los pacientes. Así es que me complace realmente presentar al doctor Christopher Crane y les pido un aplauso para él, por favor.
Buenos días, es un honor que ustedes me invitan a Ciudad de México, es mi primera vez y me gusta mucho. Gracias por todo y gracias por Erika por tu hospitalidad. Okay. Entonces, inglés. Okay. I was asked to talk about biliary cancers, and it's a very diverse group of cancers where sometimes radiation has a role in the adjuvant setting, sometimes it doesn't, sometimes it has a role in the palliative setting, sometimes it doesn't. Okay. Let's see if we can, how do I advance it? Oh, sorry. Okay, so the first consideration is the pattern of disease spread in these biliary cancers. I'm going to focus on Intrapatic cholangiocarcinoma and Hyaluronic cholangiocarcinoma because I think these are the two diseases where I think radiation has a role that we can identify based on the rationale and the data that are available. Surgery is a very effective palliation for intrapatic cholangiocarcinoma. There's a major median survival benefit. If you can achieve similar local tumor control with palliative treatments, you should achieve a similar survival benefit in that group. But however, 70 to 80% of patients have distant metastatic disease eventually, which is a competing risk that undermines the value of, at least now, giving an adjuvant radiation approach for a positive margin, for instance. Hyaluronic cholangiocarcinoma, on the other hand, has a more local and regional pattern of spread after surgery, and the positive margin rate is higher. It has a lower distant metastatic spread rate, and these patients are almost very, very commonly die of their local disease. Distant metastatic spread is less common. So considering adjuvant chemoradiation for these cancers, say for instance in the setting of positive margin, we have to take into account the pattern of disease recurrence and spread, the competing risk of distant metastatic disease, the margin status, and for instance, if there's a positive margin, radiation makes up for that many of the times, but chemotherapy may not. There's also the competing risks of comorbidity and mortality from progression of the local disease. And then if the cancer does come back, is there anything that we can do? And I'll talk about that when I address these individually. The bottom line, though, is that the reconstruction prevents a salvageable dose of radiation to be given in the setting of Hyaluronic cholangiocarcinoma, but not always an intrapatic cholangiocarcinoma. So you can have another opportunity to salvage a tumor that has isolated local recurrence. Now, I'll focus on Hyaluronic cholangiocarcinoma. In those settings, the margins are frequently close and often positive. There's a local regional pattern of spread. The transplant experience in the United States indicates that radiation made a big difference. I know this is controversial, but radiation made a big difference in the success of that curative strategy. Small cohort studies show that radiation makes up for a margin positive disease. I'll show you the available data, but they're very limited. Sorry, I didn't get my most updated slide set loaded, but margin-positive disease is a very strong predictor of poor outcome in hyaluronic cholangiocarcinoma. Nodal involvement, tumor grade, and lymphovascular space invasion are likewise prognostic factors, but the most important prognostic factor for 5-year disease-free survival is the margin status. And local regional recurrence is a leading cause of death. A study from Memorial Sloan Kettering showed this with patients who had resected hyaluronic cholangiocarcinoma. 60% of the patients had isolated or had a component of local regional recurrence. So this is a lot different than intrahepatic cholangiocarcinoma, where the isolated local tumor recurrence rate is much lower. So just to review the transplantation experience, and I know somebody in the first row might not agree with some of this, but the initial transplant experience for intrahepatic cholangiocarcinoma, for extrahepatic cholangiocarcinoma, for hyaluronic cholangiocarcinoma, was not successful, and that's because of the local tumor recurrence rate, which was very high. 47% of patients had local or remnant recurrences. Publications in the 1990s and almost abandoned this, or suggested that we abandon this strategy because it was not successful. And subsequently, the investigators at Mayo incorporated preoperative chemoradiation with brachytherapy, and then other institutions adopted this strategy. And the current regimen that is, I think, the most straightforward to use is not to use the intraluminal brachytherapy, but just simply external beam radiation with concurrent 5-FU to a dose of 60 gray. And in a group of consortium of 12 U.S. centers, the 5-year overall survival among the patients who went to transplantation was 50% survival, so it went from 20% to around 50% survival when radiation was included in the treatment. And in these smaller tumors, it was even better. There was 25% or so dropout while patients went on the list after their preoperative therapy. So this suggests that local tumor control was an important component of the success of this therapy. So adjuvant treatment studies are very limited. This is a comparison of 2 studies that were among the first 2 that were reported to evaluate postoperative radiation. Ours is on the left. Sorry, the one on the left is from Johns Hopkins, where patients were, the worst patients were selected to get radiation, and they had a similar survival as those that did not get radiation. There were more hepatic artery and hepatic parenchymal invasion in the patients who were selected for radiation. They concluded that radiation was not effective, but there was a huge selection bias. We had a very similar finding at MD Anderson in our study, where the worst patients with positive margins and the patients with positive nodes got radiation. Those with negative nodes and negative margins did not. And we had, again, very similar outcomes in these higher risk patients. We concluded that radiation made up for the higher risk features and led them to have very similar outcomes to the patients who had negative margins and negative nodes. So similar data sets, but different conclusions. The first author of the Hopkins study moved to a different institution, Medical College of Wisconsin, and was the first author on this paper looking at their experience with treatment of hyaluronic cholangiocarcinoma with chemoradiation, and had a different conclusion this time with a suggestion that chemoradiation improved overall survival. The top curve is the patients who received postoperative chemoradiation, and even better results in the more recent outcomes. There are a couple of studies that have focused on positive margin patients from Japan. This one showed improvement in survival in the margin positive patients with the use of intraoperative radiation and postoperative radiation compared to those who had positive margins who did not have a postoperative adjuvant treatment. A similar study from Yonsei University in Korea showed, in the upper panel you see positive margin patients had an improved survival when chemoradiation was used compared to when it was not. And similarly, disease-free survival was reduced with the use of chemoradiation. So some suggestion that at least with the positive margin patients, there's an improvement in disease-free and overall survival, probably from controlling the local and regional disease. There was one study published by Edgar Ben Joseph and JCO. It's a prospective phase 2 study from SWOG, 80 patients that included gallbladder and hilar cholangiocarcinomas. 68% of them were hilar. 32% of them were positive margins, so 1/3 or so. And again, a similar finding that the patients who had positive margins had a similar outcome as those who had negative margins. Everybody got radiation, but certainly a suggestion that these positive margin patients do not do poorly if chemoradiation is part of the treatment. So unfortunately, this does not show up, but this is the AHPBA consensus statement. So I was fortunate enough to be invited to be part of the AHPBA consensus statement. I was the only radiation oncologist in the room. But the top bullet says that chemoradiation should be offered to people with a positive margin. The second bullet says that they should be offered chemoradiation if they have positive nodes, and for others it should be considered. So it's a consensus. Whenever surgeons don't have enough data, they have a consensus conference and write a paper about it. But if you contrast that to the ASCO consensus conference, and the meanings of these words are maybe a little bit subtle when translated into Spanish, but the little bit different take on it from the ASCO panel was that adjuvant capecitabine should be offered as an adjuvant treatment because of a randomized phase 3 trial. And then in the margin positive patients, chemoradiation may be offered. So it's a little bit less of a strong word, but the only way that it could be should is if we had randomized data, which we will probably never have. So I think that's about as strong as of a recommendation as this panel could have come up with. Now moving on to intrapatic cholangiocarcinoma, this is a National Cancer Center database study showing surgical resection with adjuvant therapy in blue, having the best outcomes. And then in pink, there's a survival that's not quite as good with surgery alone, and the other two are without surgery, certainly worse median and overall survival. You can see that surgery is a very effective palliative treatment, at least now until we have better adjuvant treatments. There's a major median survival benefit, but only about 20% of patients are alive at 5 years. So if we can have and that's because the competing risk of distant metastatic disease. Here's an example of a patient actually that we treated with chemoradiation, ablative radiation, to the liver who had intrapatic distant metastatic spread in segments 4A and 4B. That is an example of what happens in these patients. They have intrapatic distant metastatic spread and also extrapatic distant metastatic spread very commonly. But the main reason that they die is because they have liver failure from their primary tumor. So that's why controlling the tumor is very important. So this is a summary of recommendations for adjuvant treatment. I think in positive margin patients and positive node patients, there is a good rationale to use postoperative adjuvant treatment for hilar cholangiocarcinoma. However, in intrapatic cholangiocarcinoma, this question very often comes up. If there's a close or positive margin after surgical resection, the question comes up, should we include radiation as part of the treatment? And I actually feel that it's better to wait and see if this is going to result in an isolated local recurrence, rather than treating all of the patients who have a 70% risk of distant metastatic failure with chemoradiation. We could focus on the ones that have isolated local recurrences, because if there is an isolated local recurrence, we do have an opportunity to give high-dose radiation that will ablate the tumor 80 to 90% of the time, and I'll show you some of the data that we have about that. Didn't want to talk too much about gallbladder cancer, but there's also a similar problem in gallbladder cancer where there's a high risk of distant metastatic spread. So we're very careful about recommending chemoradiation in these patients, and typically we'll give chemotherapy for a fairly extended period of time before considering radiation in patients with positive margin. So I'll skip over to definitive treatment of comparing and contrasting intrapatic cholangiocarcinoma versus hilar cholangiocarcinoma. Intrapatic cholangiocarcinoma patients typically die from their primary tumor if it's not removed. And that's because they have portal venous obstructions, hepatic venous obstructions, and obstructions of the biliary tree that lead to hepatic parenchymal loss. There's an ability, if they're inoperable, if we give a high enough dose of radiation, we can control the cancer that will result in prolonging the survival by preventing this liver failure from the tumor. So these are the areas of concern: the confluence of the hepatic veins going into the IVC, the biliary tree, and the portal venous branches are areas where if the tumor gets access to these areas, it can cause a gradual process of liver failure. So here's an example of a patient that illustrates this that I saw when I was in Houston at MD Anderson. It was a 51-year-old lady who was presented in tumor conference who had a large intrapatic cholangiocarcinoma with only one intact hepatic vein, the right hepatic vein, and it looked like the tumor was about ready to cause an obstruction. And by the time she was referred to our clinic, she was in liver failure with elevated transaminases over 1,000, rising bilirubin. You can see the congestion in the liver from this simulation CT that we did. And so, being in liver failure, we didn't treat her with radiation. And we had a very serious conversation with her about the fact that she was in liver failure. She was actually treated by my colleague, Malin Javle, with Avastin and irinotecan, and we said that, things are most likely not going to go well. But actually, she had collateral blood flow develop, collateral drainage of the liver from the umbilical vein that enabled her liver to drain, and she responded to chemotherapy. And then we went back and gave her ablative doses of radiation. She lived 2 more years from the time that she was in liver failure. But this case actually just illustrates the fact that the tumor can cause liver failure and a related mortality, and it does so very commonly. Now, I'll get to the series that we published from MD Anderson in a minute, but this is the pattern of disease-related death in those patients. It was a dose escalation analysis, and the patients who had inadequate tumor control with lower doses of radiation died from liver failure related to the tumor 90% of the time. And this is the same case I just showed you. The different regimens that we use now that are ablative that result in 80 to 90% tumor control are listed here. It can be given in 5 treatments, 10 treatments, 15 treatments, or 25 treatments. The most common thing that we do in liver tumors, since they're mostly large tumors, is we give this treatment in 15 or 25 treatments. But the dose of radiation we're trying to achieve is 100 gray, and it works extremely well and is well tolerated, but it's a very specialized, I'd say, practice, and not many centers in the United States offer this treatment for liver tumors. These doses are based on a dose escalation study that we did at MD Anderson of 80 patients with intrapatic cholangiocarcinoma. We made a change in 2007 to give these ablative doses. And that was with the availability of new technologies, such as proton therapy and image guidance with breath hold to correct for respiratory motion. And these are the survival curves. You can see on the left is local tumor control, and on the right is overall survival. The blue line is ablative dose, and this is from the time of diagnosis. And the gray and yellow lines are with lower doses of radiation, using, again, the 3 and 5 week regimens of stereotactic radiation. There's a good correlation between the tumor control and the overall survival, as you can see. Now these 2 regimens are what we use in everyone, and we end up with about 80% local tumor control, which we reproduced at Memorial Sloan Kettering as well. We had a prospective study that looked at this as well that we did with Mass General, and this is with proton therapy only, and we had HCCs and 50 intrapatic cholangios, resulting in 90% tumor control in the HCCs and 70% tumor control in the intrapatics, but we subsequently increased the dose of radiation for the central tumors. That's resulted in better control than that. And you can see very good median survivals with tails to the survival curve that are suggestive of excellent local tumor control, prolonging survival and excellent long-term palliative benefit. Here's just an example of a large tumor that was inoperable who received 100 gray in the center of the tumor, 75 gray in the periphery. The equivalent doses here is even higher than 100. It's 150 in the middle of the tumor. And again, it has to be done very carefully, but in the right lobe, it's fairly straightforward to do this. And the first restaging scan, she had a complete response. She's alive now 2 years later with 2 small intrahepatic recurrences that are and she's back on chemotherapy. That's a pretty common story. Here's another example of an ablated tumor in the left lobe. So a question comes up about giving preoperative chemoradiation for these tumors to downstage them. They don't really change their anatomies so that we would say, well, now the anatomy is different, that so much that surgery would be possible. It's a little different than what we see with chemotherapy. So in my opinion, we should be either doing definitive surgery or definitive radiation if they can't have surgery. And there's really very little, or there's really no neoadjuvant data in the intrapatic patients. And it's also unclear whether or not liver resection would be safe after ablative doses of radiation. So we really don't think about it to downstage. Patients often ask this, but it's more of definitive palliative treatment. Now this is often comes up as well is what about the role of embolic treatments for intrapatic cholangiocarcinoma? We already talked about it for HCC where it has a long track record of success. But in intrapatic cholangiocarcinomas, which are not as vascular, there really isn't the same track record of success. And this is a study which I recommend reading if you're interested in this topic, comparative effectiveness of hepatic arterial therapy for intrapatic cholangiocarcinoma. I inserted the ineffective because I'd say comparative ineffectiveness is probably a better title. The very top group is the hepatic infusional 5FU group of patients, and that's really dominated by the Memorial Sloan Kettering group that have achieved very excellent local tumor control and median survivals in this group of patients. But 80% of the patients in their studies have been first-line patients. So the closer you move these treatments to first line, the better the results are going to be. And if you look at the results with embolic therapies, transarterial chemoembolization, TACE, median survivals are between 10 and 12 months. DEB-TACE, which is an advanced supposedly, is about the same. Y90 is about the same. So the more the recent generations of embolic treatments have not changed the fact that these tumors are probably incompletely treated with embolic treatments. Now, what about definitive ablative treatment for hilar cholangiocarcinomas that are unresectable? We don't have the same results in this group of patients because they all have stenting, they all have colonization by E. coli of their biliary tree, recurrent bouts of cholangiocarcinoma, of cholangitis that lead to eventually progressive worsening of their biliary sclerosis, and they end up dying from that. The median survival is around 12 months with standard doses of radiation that you can see here, ranging between 10 and 16 months. Even when intraluminal brachytherapy is used, the best study is from Duke University. They had its tail of the curve of a couple of patients, but these are really anecdotal events that happen if any of these patients do live for a very long time. We give the ablative doses to these patients because it's well tolerated and there's no downside, but very little expectation of longer term survival because of this competing risk of the local morbidity of cholangitis that's recurrent, and we really do not have a good solution for other than surgical resection. So this is just repeating that, that relentless episodes of cholangitis is the mode of death in the Hyalars, and for the intrapatic cholangiocarcinomas, it's obstruction of the venous inflow and the venous outflow, and obstruction of the biliary tree that leads to, is the primary cause for for tumor-related death. So the best indications for radiation in biliary tumors, in my opinion, are for intrapatic cholangiocarcinomas for palliative/definitive ablative doses of radiation. Lower doses may help, but they're not going to help as much. And if we can give ablative doses of radiation, it will achieve a major median survival benefit. And that dose is 100 gray, twice the normal dose that we typically give. The role of adjuvant chemoradiation in these patients is very limited, and so I very rarely do recommend adjuvant chemoradiation in these patients. And when I do, it's when I look at the postoperative anatomy and see that I cannot. I try to picture where the margin is positive, and if there's a local recurrence there, whether I'll be able to give an ablative dose. And often there's small bowel duodenum or there's colon stuck to that side of the liver, and then in that case it might be reasonable to give after chemotherapy. For hyaluronic cholangiocarcinoma, I think it's reasonable to give postoperative chemoradiation for positive margins, possibly for positive nodes, although the data are, there are really no good data to say about positive nodes, but there is a local regional pattern of spread. For the rest, it's really very unclear, and there's no consensus. The data are extremely limited. Sorry that is all over the place, but somehow my slides got corrupted. But so I'd just like to thank my colleagues as well at Memorial Sloan Kettering, Ghassan Abu Alpha, James Harding, Mike D'Angelica, Bill Jarnigan. Peter Allen's name is under acknowledgments there to Peter King, and our gastroenterologist who help us a lot with these patients. Thank you very much for your attention.